to all of you. A warm welcome to this webinar, Addiction and Illness, a very topical subject worth having a wonderful debate on that. And we also have two other panelists. It gives me again immense pleasure to introduce Mrs. Renika, clinical psychologist who has done her MPhil from IBAS, Delhi, and she is again has lots of experience working in this area on a day-to-day basis with residents of various addictions, and she will be talking about the psychopathology and what are the psychological reasons or causes for addiction. Now, again, that's one more dimension adding to the causes of addiction. She, with her vast experience and knowledge, she will be talking about these psychological aspects.
Good morning to all. Welcome to Addiction as an Illness series. Today I'm going to talk about psychological theories and models of addiction. The objectives of today's presentation: why we need models and theories of addiction, and discuss major psychological theories and models of addiction, understand treatment applications of these models. Why we need the theories and models of addiction. We know addiction is understood as a complex disease involving interactions among brain circuits, genetics, the environment, and an individual's life experiences. For better understanding of the complex science of addiction and for treatment implications, we need to understand theories and models. These models are not limited to illicit drugs, but also can be applied to alcohol, tobacco, and even non-pharmacological addictions, such as gambling, compulsive use of internet, that is behavioral addictions. Let's begin with understanding 4 conceptual models of addictive behavior. The moral model, which holds little support for this, little support in literature. Then we are familiar with medical or disease model, which says people are not responsible for creating or solving their own problems. Enlightened model says people are responsible for creating but not solving their own problems. According to the compensatory model, people are responsible for solving but not creating their own problems. Of these 4 models, the compensatory model is the most similar to the biopsychosocial model. Let's look at the biopsychosocial model. We all know that science has not yet discovered a single factor that can explain why some people refrain from substances, whereas others abuse and become dependent on it. Instead, the available evidences suggest that biological, genetic, personality, psychological, cognitive, social, cultural, and environmental factors interact to produce the substance use disorder, and multiple factors must be addressed in prevention and treatment programs. This model of biopsychosocial approach is a more holistic, and the treatment becomes personalized and flexible here. The approach at a Cadabams hospital and Cadabams Anunita De-Addiction and Rehabilitation Center is based on biopsychosocial model, and we have a team of psychiatrists, clinical psychologists, psychiatric social workers, counselors, and other treating team members for holistic approach for making the treatment more personalized and flexible. Let's look into the learning theories. Learning theories have had a strong influence in our understanding of the causes of addiction as well as on planning intervention strategies. The relevant learning theories include operant as well as classical conditioning principles. And we very well know during our CBT practice, we explain clients, the use of your substance is learned behavior and it can be unlearned. Further, we explain that it is not survival instincts like hunger or thirst. How Paulo's dog learned or got conditioned and deconditions, human too can. So unlearning of your addictive behavior is a possibility. So classical and operant conditions work together to produce a chain or a sequence of behavior, that is classical conditioning as an antecedent and operant conditioning as a consequence. For example, encountering a liquor store may serve as a classically conditioned cue for a problem drinker, which results in craving. In turn, craving may then serve as a cue to consume alcohol, and this behavior may then be negatively reinforced by elevating the problems or stress or negative mood of the person. By determining and understanding the behavior chain involved in addictive behavior, intervention can be aimed at breaking the classically conditioned link here, a cue and the behavior, by altering the reinforcement for the behavior or for both. Higher the frequency of substance use as a reward and faulty coping mechanism increases the likelihood of dependency on the substances and erosion of alternative coping mechanisms. Hence, coping skills training is an important component in the treatment and rehabilitation of people with addiction problems. Let's look at the social learning theories. These basic learning theories are taken a step further with an understanding of social learning theory. It's not necessary that people have to experience rewards and punishment themselves to learn the addictive behavior. It can also happen through the modeling or observational learning. The observational learning, people learn to imitate both precise as well as general class of behaviors. For example, we hear in our clinical practice patients saying, I saw my dad or uncle drinking and making fun to get rid of their business related stress. Yeah, even I need something to do away the stress. Cannabis relaxes me and helps me to focus on the studies. So here, person is not, the general class of behavior is modeled through the observational learning. The concept now, look at the expectancies model. The concept of observational learning leads to another set of psychological principles in addiction, that is drug or alcohol expectancies. Expectancies are the set of beliefs individuals develop regarding how these substances might affect them. The heavier drinkers report more positive alcohol outcome expectancies and fewer negative outcome expectancies than the lighter drinkers. So I can recall here my patients saying, no way, I can't relax in evenings or on my holidays without drinking or smoking. I have been doing this all these years and it has helped me. Here we see that the client has a high expectancies. And information theory explains how people perceive information from the environment, store it in a short-term memory and transform to long-term memory and retrieve it in order to influence their behavior. Information processing theory has its implications on understanding and treatment planning of addiction. Let's look at the personality and temperamental aspects. This concept presumes the existence of specific personality trait that characterizes individuals who develop substance use or addiction disorders. Personality variables that impact later substance use include high novelty, sensation seeking, low harm avoidance, negative affectivity, and reward dependence. Similarly, certain temperamental variables of low sociability, impulsivity have also identified which lead to the substance, which are predictors for substance abuse in the adolescence. A preview of pre-existing literature on the subject reveals that cluster B is the category with the most evidence of a connection to substance abuse. They are most likely to act impulsively, which forms the risk factor for addiction. More specifically, studies have shown that the substance abuse and borderline personality disorder are common bedfellows. People with aggression, lack of empathy, that is, people with antisocial personality disorder, have a higher rates of alcohol abuse and alcoholism than the general population. Now, take a look at the psychodynamic, attachment, and self-medication perspectives. These psychological approaches suggest that A person uses drugs to fill a terrific void in their emotional lives or as a means of quieting voices of inner conflict. A person might be using drugs to find relief from physical or emotional pain. These are called self-medication theories. In this line of thinking, a person uses substances to avoid or blunt their negative or disturbing feelings, as seen in the Pink Floyd song lyrics, I have become a comfortably numb. Pink Floyd is a rock band in 60s in UK. We know that we do observe in our clinical practice that co-occurrence of PTSD and substance use disorder. Now take a look at the socio-cultural model. This model has become popular in the last 15 years. Unlike other models, it focuses on society as a whole and not just on individuals. This model is based on the idea that the type of society in which people live has an impact on their drug abuse. In particular, this model makes a link between inequality and drug use. Here I feel it's worth mentioning a novel called Outsider by H.E. Hilton, very beautifully predict this model. Psychological factors in treatment of addiction. Let's look at readiness to change or motivation and self-efficacy. Research has found that motivation to increase the likelihood that someone will seek out treatment and complete the program is successful in changing his behavior or substance use. Hence, in our clinical practice, we encounter very often a question by the patients and their families how successful treatment will be. I have opted for a best hospital. We have all the supports. So, क्या completely ठीक हो जाएगा? So we explain them. It depends on the motivation of the client. The core aspect in the recovery is motivation. According to the trans-theoretical model, a leading model of behavioral change that was developed to explain how people change addictive behaviors, readiness to change is a function of decisional balance or the cognitive appraisal of pros and cons of the changing. People for whom pros of changing outweigh the cons of changing their substance use are more motivated to change their behavior. The therapeutic style of motivational interviewing has shown to be effective in bringing out the readiness to change in clients. Look at self-efficacy. Self-efficacy is a cognitive factor that is crucial to recovery from addiction. In order to refrain from using substances, one needs to believe that he or she is capable of managing difficult situations in other ways than using the substance. Self-efficacy can be built through experience and exposure to different behavioral options. For example, when a smoker forgoes a cigarette in favor of his brisk walk and manages his stress, he or she can build self-efficacy by proving to himself or herself that response other than smoking for the individual and is possible and that stress can be relieved in the absence of cigarette smoking. Hence, in behavioral intervention, alternative pleasurable activities are taught to the clients. The greater experience one has with using coping strategies other than substance use, the greater his or her self-efficacy becomes. Motivational interviewing support the self-efficacy. To conclude, there is a great deal of evidence supporting the biopsychosocial model of addiction, which gives weight to biological, psychological, and social factors in understanding and development and progression of substance use problems and developing a successful treatment program. Thank you.
Can you hear me?
Yes, doctor.
Right. Yeah, that was an elaborate presentation where you talk about different models, which learning models, social model, and observational theories, all that you've talked about it. Now, by the time they come to you, actually, many of them would have already, either become either habituated, become addicted as such. Now, you yourself posed the question as in where will the person get well, what will happen to them as such. Now, from your perspective as such, it's good to know, understand that there is a new biological basis, psychological basis, and of course, Swarupa has talked about the other things. So, the understanding the psychological basis, uh, from your point of view, there are different theories, but what is right now? Is it more of informational, the processing? Which one is more acceptable now? Because psychodynamic, all that is perhaps a little more, older theories as such. What is much more topical? Just wanted to ask you.
Yes, Doctor. Learning theories have a huge impact on understanding the addiction process as well as planning a treatment strategies. So even the information processing or cognitive theories. So how people learn these behavior and how people can unlearn these behavior, CBT approaches, and as I also mentioned about the um, motivational interviewing approaches have a very relevance in planning behavioral interventions.
So there are a lot of theories. Some of it we more of historical importance, but we can concentrate on the much more
Yes,
topical ones.
yes,
Yeah,
yes.
another question which I wanted to ask is, because that's one more from a practicing psychiatrist point of view, it's about the personality characteristics. You stressed on the cluster B traits and the use of drugs. At the same time, the use of drugs over a longer period of time can have personality change also, right? So
Yes, yes.
how do you explain that, Mrs. Brent?
So, doctor, we need to conceptualize the case, understanding how personality factors have led for the development of addiction problem, or a chronic addiction has led for certain changes in their behaviors, and the person's readiness to change, keeping in all these points, that is having a biopsychosocial model or a complete conceptualization helps us to prioritize the treatment plan.
Right. Your take-home message.
Yes, doctor, take home message is addiction is a treatable disease, if not curable. Yes, lot of contribution from psychological point of view. People are looking for it. That's how we see in the OPDs people coming. I want only counseling. I'll get better. I will stop. But ultimately they fail. Then they get ready for, yes, I will take medicines. I'll get admitted into the rehabilitation center. So holistic approach and contribution from behavioral sciences is significance in recovery process.
Right. Thank you very much, ma'am. As we wind up, thank you very much to all the three presenters, and thank you, Mr. Sandesh Cadabams and Dr. Sunil, for the opportunity.